So, ladies and gentlemen, wishing again a very good morning. We would once again like to welcome you all here in 16th Annual Conference of Venous Association of India, as we are here in this scientific program, and definitely we are moving for our session 2, Superficial Venous Disease 1. And now we are here with our chairperson on stage, Dr. Roy Varghese. Can you please put your hands together for our chairperson and Dr. Ile. Next, here we are with our panelists, Mr. Hanish Kataria, Mr. Ranjeesh, and Mr. Pushpinder Singh. So let's continue with the session 2. Over to our chairperson. So here we are with Dr. Prakash Ramamurthy, sir. Thank you so much. So over to our chairperson. Thank you.
Can I invite the first speaker, Rahul, for the update on management of varicose veins, please? I request all the speakers to keep up to the time limit. We are already running late by almost half an hour.
Yeah, sure. Thank you. Thank you. Good morning. I'm going to go through what all treatments are available for the management of varicose vein as a whole, because in the next 2 days, we are going to see all the treatments in great detail. So I'm just going to touch base what all treatments are available in the world. So we know about the recent advances in the SEEP classification, which has been changed in 2020, and there has been inclusion of C2R, which is a recurrent varicose vein. C4A, B, and C has been divided, and there is an addition of 6CR, a recurrent active venous ulcer. Now, there are a huge amount of treatment options which are available, as you can see from the chart here, and there are some advantages and disadvantages of each technique. Now, surgery under local anesthesia with tumescence and foam sclerotherapy with ultrasound-guided marking is a very cost-effective treatment, especially in an Indian government hospital setups. And we teach people to do these techniques under local, and patient can walk home, and you can get a very good results at a very low cost. Then there is the latest advancement in terms of wavelength of the laser. So 1940 is quite effective. We have been using it from 5 years now, and it is more water absorbent. So what we want to do when we give a laser is we don't want to burn the lumen of the vein, we want to burn the wall of the vein. So it gets more absorbed, the heat, into the wall of the vein. We use less energy because you get more absorption, so you get less ecchymosis, you get less cord formation, and you get a better closure rate. So this is something new which has happened in the last few years. Then coming to the type of fiber. So bare fibers definitely causes you more hematomas and more bruise. So radial fibers should be used. Now single ring, double ring, or 5-ring fibers, so there is no study comparing head to head, but what we get from the studies is that there is not much difference in terms of what fiber you use. So the cost definitely of the single ring is much less. Considering, look into the size of the varicose veins, so actually talking, there are hardly now any contraindications for treatment of varicose veins by minimal invasive method, except if you have got, sometimes a venous aneurysm at the junction, something like 3-4 centimeters of SFJ or SPJ, then you may have to do an open repair. But otherwise, such huge varicose veins, you can go through under local anesthesia, under laser, and on table, you can get a fantastic results in these patients. Another thing which is nowadays talked about in few years is, because there was a recurrence of the varicose veins once you do the laser into the anterior accessory saphenous veins. So we think that if we close it at the junction by a thermal crossectomy or a glue crossectomy, you may be able to get a better results, because you are going to close at the junction and there is not going to be enough reflux from the SFJ into the anterior accessory saphenous vein, and you can get a pretty good results. And this is a very standard treatment now. In a lot of patients we do treat this when we found that the junction is hugely incompetent. Then coming to the perforator closures, so we have been doing the closures if their perforators are small with a foam. Then if the perforators are bigger, then we used to use a laser or a radiofrequency. and we can use this, and this is like a very pretty standard treatment now. And in the last 1 year, we have been working on glue closure of the perforators, and which we are finding a very good results. You can use a radio frequency, you can also use a steam ablation, and you can also use a microwave technology. All these are thermal technologies which can be used with some pros and cons of each technology, especially like non-laser technology. Because there are, when you use a laser, you have to follow up a lot of safety protocols with the laser. We could say type 4 laser. So there are some hospitals in Europe where there is a huge issues with finding, following the protocol. Then a non-laser machines can be used. Then we have got non-thermal techniques, divided into 3 groups. So one is a mocha, another is a glue, and third is a foam. You have to remember all non-thermal techniques will be slightly inferior to thermal techniques, but the advantage is you don't have to use a tumescent anesthesia. So when we come to the mocha, so there are 2 basic techniques of phlebograph and Claravin, which has been investigating. And if you look into the results published at 5 years, so they are definitely inferior to thermal. In thermal lasers, closure rates are reaching up to 99.9%. So it's nearly a very, very robust technique in terms of thermal. So all these techniques, they work on the basis of they scrap the inside of the intima of the vein, and we put in the foam or the liquid sclerosant, and we hope that this sclerosant goes and damages the media of the vein wall, because our main thing is to damage the vein wall. So unless the foam and everything goes inside the vein wall, the results will be inferior. So in this, we scrap and we inject, and we hope the results will be good. So you can get a fairly good result in the short term, but long term is a problem. In terms of glue, there are various glues. One is Medtronic, another one is a Turkish glue. There are 3 different types of Turkish glue. Everybody has got basically a polymerization difference. So that's the basic difference. Now glue is got a very good results, a very good advantage in obese patients where you don't have to use local anesthesias, and you can get a fairly good results. A new technique which has been investigated is a high intensity focus ultrasound, and basically how it works is that you can use an ultrasound transdermal and burn the vein from the skin, and we can get a fairly good results in the short term. So it's still under research, and we are going to get the results, long-term results shortly. So we will see how it goes. Cosmetic varicose veins like this, they can be treated by various techniques. The new techniques which is being investigated is by an NDY1074 laser, or something called as the transdermal laser technology with the injections. And you can get a pretty good results in certain aspects like a facial veins and in the foot veins. The spider veins can get a very good results. So in conclusion, the treatment for management of varicose veins is evolving and very patient friendly. And I think minimal invasive treatment is a gold standard. Thank you.
It's a brilliant presentation, Rahul. Thank you very much. We'll take questions towards the end of the session. In podium, this is podium A. So in podium B, are we ready for the online presentation? The next one from Russia by Dr. Denis Borsak, comprehensive approach to 2-step varicose vein treatment. Is an online presentation. Are we connected?
So, do you see my screen?
Yes, Dennis, we can hear you. Please go ahead.
Okay. So my talk will be about comprehensive approach to 2 steps varicose veins treatment. I have nothing to disclosure. So just a second, please. So today we have 3 basic approaches for treatment of varicose veins, treatment of acute veins and tributaries simultaneously, treatment of tributaries only, such as the SMILE method, and also treatment of saphenous veins only and observation of the tributaries. Of course, we do have Shiva method, but today I will not talk about it. So, of course, both of methods of tributary treatments has their advantages and disadvantages. I will not stop here on it, all of you know that. And so the biggest problem of sclerotherapy is hyperpigmentation, non-target superficial deep or superficial or deep veins after sclerotherapy. Of course, we also have some complications of microphlebectomy, but it's quite rare. But the biggest problem is could be painful for some cases. And as our teachers, our mentors said that the best surgery is the one that hasn't been done. So that's why after appearance of these less invasive methods of the treatment of saphenous veins, isolated saphenous veins treatment becomes more attractive for us. And the purpose of our investigation was to understand the fate of untreated tributaries after isolated endovenous laser ablations of saphenous veins. So here is our material. Investigation included 374 patients, 420 endovenous lasers in all of saphenous vein systems, in GSV, ASSV, SSV. All of patients were had CT flares, and all the tributaries were preserved. And we compared proteins for 1 and 2 weeks. Here is the follow-up, next day, 7 day, and 2 to 3 months after treatment. And here is the results. So in 15% of patients, in 20% of patients, tributaries completely disappear. So patients become had 0 to 1 less after treatment. In 65% of treatment of patients, so we had significant reduction of tributaries, and also, sorry, I listen. I hear okay. I hear somebody. Could you please audience voices? Okay, so, and in 65% of cases, tributaries significantly becomes less, and in 50% we had no changes of tributaries. But my talk will be about comprehensive approach nowadays, not about these results. So, but as you can obviously see on this pie chart, so again, in 20% we had complete reduction of tributaries, in 65% of cases, tributaries significantly become smaller, and in 50% they had no change. So here are the results of thrombophlebitis. So we had it in 10% of cases, but two important things. So firstly, in 3/4 of these patients, we had significant regress of clinical class and severity score and satisfied cosmetic results after 2 to 3 months, and all of patients included in this study. So we didn't choose patients, to make results better. So we included patients with huge veins. So that's why we had 10% of cases of thrombophlebitis, in my opinion. So, and we have future in this way, so to have reduction of this amount of patients with thrombophlebitis. So, and in 80% of cases, we had a regress of symptoms of chronic venous disorders. So after just isolated EVLT, here is quite a couple of examples before and just after saphenous vein treatment. So complete reduction of varicose vein tributaries. And here is another case. So tributaries on the knee, it's difficult place, not the best place for microphlebectomy. And here just the result after isolated endovenous laser. So very fast, quickly procedure, and quite a good result. And here is fantastic result. So complete reduction of edema, of hyperemia on this so area of calf. So, and here is a fantastic result, and we can treat tributaries the second step. The biggest problem of literature that in all of the studies, doctors tried just to compare simultaneous treatment and delayed treatment. But the biggest problem of all of this study that they included all of the patients. But in our clinical daily practice, we use this tactic only in 80%. And in case of, for example, huge tributaries diameter or something else, so we use microphlebectomy simultaneously. So, but the other problem that we have subjectivism when we use, so when we choose tactics. So for simultaneous or two-steps approach. So, but I suppose that all of you will agree with me that if you knew before the treatment this result, you would choose isolated tactic, because if you knew before the operation that you would have this result, so all of you will agree with me that you will use isolated EVLT. So the biggest problem that we don't know how to understand the result of isolated EVLT today, but we are working in this way, and in the future we will have some hemodynamic study which will help us to choose this tactic. But nowadays we use we have subjectivism, and we use just this personalization criteria. I want to draw your attention on this slide because it's quite important. This is the last slide. That today we use this personalization criteria, such as patient's preference after explaining all of advantages and disadvantages of both tactics, diameter of tributaries, number of tributaries, the specificity of the protrusion of tributaries above the skin surface, the amount of the fat tissue in this area, the thinning of the venous wall, the presence of local phleboctasias, the presence of trophic disorders of the skin, edema, ulcers, accompanying illnesses, place of residence, distance from the clinic. In Russia it's quite important because we can sometimes have patients from far north, so thousands of kilometers who can come, and of course for them simultaneous treatment is preferable. The ability to come to follow-up examinations and subsequent procedures. Localization of tributaries, knee, thigh, calf, foot, reason of treatment, aesthetics, symptoms, risk of complications, the attitude of the patients to the aesthetics, and here may be influenced by gender or age, venous thromboembolism in history, pain threshold, season, average air temperature, and here it's also quite important because we have from 30 degrees below zero to 30 degrees above
Dennis,
zero.
can we bind up? Your time is over.
Yes, and tolerance to elastic stockings, the presence of allergic reactions in history, and physical experience of isolated thermal ablation. And here's conclusion. The tactic of isolated elimination of the venous vein has the advantages actually in summer period and among elderly patients with symptoms of chronic venous disorders. And this tactic is possible only for patients who can be exempt in follow-up period. And this direction is demanded more significant investigation with evaluation of hemodynamics, quality of life, and severity of pain syndrome. Thank you for attention.
Thanks for sticking to the time schedule. Questions will be taken at the end of the session. Can I call upon the next speaker, Dr. Gulshanjeet Singh, for his presentation on antegrade scrotal sclerotherapy into podium B. Can you load the slides here, please? I think the presentation is still in the previous slide presentation. Can you change the presentation here? Please come here, sir. That's it, okay.
Good morning to all of you. I'll be speaking on the antegrade scrotal sclerotherapy for varicocele, which is one of the modalities for the treatment of the varicocele. The antegrade scrotal sclerotherapy is an alternative to traditional inguinal or suprainguinal surgical ligation. It was first started by Tauber and Johnson in 1993. First, I'll describe the technique, step-by-step surgical technique. The position patient is put in supine in a slight antetendular position with the thigh closed. This will make the veins dilated, and thigh closure will make the scrotum superficial. Then we grasp the spermatic cord at the scrotal root level and push the vas deferens posteriorly so that the veins lie anteriorly in the spermatic cord. Then we loop around, we give a local anesthesia, I give a longitudinal incision, and then we loop around the spermatic cord. Then we give an incision to the incision in the vaginal fascia and extend the incision. After we give the incision, we see a lot of fat, and the veins lie posterior to the fat. So then we isolate Then we isolate one of the spermatic vein. After we have isolated the vein, we cannulate the vein with 24 gauge IV cannula. So after cannulating the vein, we flush the vein with the normal saline. Then we focus the renal area with the CM after putting a metallic marker. And after that, we inject a contrast into the vein. So we perform ascending phlebography using non-ionic contrast. So the amount of contrast which we inject is the amount which we have to use the sclerosant. So this will give a rough idea that how much amount of the sclerosant we have to use. Because the contrast, we have to see that it doesn't enter the renal vein. So then we inject the sclerosant using air block technique. So this is that we attach a three-way stopcock to the IV cannula. On one side, we attach a Leerlock syringe with 1 ml of air, and on the other side of the stopcock, we inject syringe with 4 to 5 ml of escarole or sclerosant. First, we inject 1 ml of air, and following this, sclerosant is injected while asking the patient to do a mild Valsalva maneuver. So the advantages of the air block technique is that the sclerosant injection speed decreases and it prevents it from entering into the renal vein or IVC on the right side. And the contact time of the sclerosant to the vein increases, so there is better sclerosis. The advantages of the Valsalva maneuver is that it increases abdominal pressure, and this increase in pressure causes sclerosis of the tributaries of the gonadal veins, and contact time of the sclerosant to vein increases, so better sclerosis. So this is an operative video. We are given an incision and we are isolating the spermatic vein. Then we are now, after cannulating the vein with 24 gauge cannula, we are injecting normal saline just to flush the vein. This is just, we are focusing the renal area under CM. And we are injecting a contrast into the gonadal veins, into the vein which goes into the gonadal. We can see the contrast is going into the gonadal vein. So the amount of contrast we inject so that it stops going to the renal vein is the amount of sclerosant we have to inject. So this is ascending phlebography of the gonadal vein. And now we are injecting, we have injected three-way stopcock and we are injecting this, pushing air, and after pushing 1 ml of the air, we start injecting the sclerosant, about 4 to 5 ml, and then we ask the patient to perform the Valsalva maneuver. And we close the wound. So we carried out this study, antegrade sclerotherapy for varicocele, a prospective study. Pre-operatively, all the patients were subjected to clinical examination, semen analysis, and color Doppler examination. The aim and objective of the study was to evaluate antegrade sclerotherapy technique, complication, and its clinical outcomes. Total number of patients were 70, number of varicoceles 80, average age was 26 years, laterality left side 55%, right 5, and bilateral 10. And grade 1, grade 2, and grade 3. The more number of patients were in grade 2. We lost to follow-up in 4 patients, and follow-up period was 11 months. The main operating time of this procedure was 15 minutes. The X-ray exposure was 3 to 5 seconds, hospitalization less than 6 hours, and return to activity was 1 day. The complications of our study were approximately 10%, and the other study carried out by Christiani et al. In 674 patients was 7.2%. The various complications epidermitis, hematoma, wound infection, and scrotal pain, then the persistence of reflux. So follow-up we did at 7th post-op day, 3 months, and color Doppler and spermiogram were repeated after 6 months of the procedure. The spermiogram, this chart shows that the preoperative count was less, but it increased after the procedure. The motility improved, and the abnormal forms of the sperm decreased after the study, and the results were comparable with the other study.
So please
The
wind up.
inability to catheterize was less than 1%. In published series, we had nil. Persistence of reflux, 2.85%, comparable with the published series, and 10% complications were again comparable.
So please wind up. We are out of time.
It should be the first choice for the treating primary varicocele, clinically effective, rapid, simple, low incidence of complication. It's a OPD procedure, rapid return to work, and low cost. Thank you.
Thank you, sir. Questions will be taken at the end of the session. Thanks for sticking to the time. The next presentation on the schedule is not happening, so we are going to the next one by Dr. Serge Macau from France on sclerotherapy, standardizing the practice. Here, this one.
Good morning, everyone. I arrived just from Paris, and I would like to speak about the sclerotherapy and the standardizing the practice for the security of the result. Just now, the definition, the sclerotherapy is the treatment of varicose veins by intravenous injection of a sclerosing agent in liquid or foam form. Now the technique, you know, you have two techniques, the top to down, it's a classical proximal to distal from France, and now it's relatively finished, but the bottom up is the Switzerland and Ireland technique. Now from the highest point and the largest leakage point, and fractionate the ejection for the safety and tributary at a later time it's necessary. It's the technique for tourné. And it's the recommendation for the European guidelines for sclerotherapy. Direct puncture, knee injections, stage technique. Now, Site and Fegan is just for the name of the two big phlebologists, Sig and Fegan, but now the technique is not used more. The material, easy to set up. You can see, easy to prepare. You know all the system to make foam, the size of the needle, and now the production of foam, more simple, it's complicated. Easy to do. You can see here the injection with catheter, easy to do, but not so simple to do. Now the pre-injection procedure, medical history, physical examination, duplex ultrasound examination, and after that, the SIP classification. I think it's important. And after that, you can decide yes, no, or maybe. And ask to the patient if he agrees with the treatment or if he disagrees. Needle, syringe, echo Doppler, and duplex, and treatment, it's a good way for the recommendation. Now you can see the technique, the longitudinal view with the needle, and the transverse view for the cross-section. I think it's really a question of doctors, and it's not really, both is good. And the main point for in the two cases, the spasm feeling for when we have a treatment, to be sure it's not necessary to inject more when we have a spasm. Now, the point you can see it's the European guidelines for the sclerotherapy. Same, the biggest to the small, and on the top and the bottom. Now some example. I think if it's possible to see, yes. You can see here a visual sclerotherapy without Doppler. You can see the needle. Well, you know that very well, but I think it's not so bad to remind some time. Now the second one with the night technique. I think you know too. The idea is you have a better one view of the treatment. Now, every time you look about the complication, and if you look all the complication, you have in final the severe complication and the benign complication, but if you look the liquid and foam, you can see the case is relatively rare, and the main problem is the skin necrosis on the large tissue for the severe complication, of benign complication if only for the minimal necrosis. But it's rare, it's only very often a question of technique. How to prevent the neurological complication? The recommendation 2 from the European guidelines, we recommend to consider the following absolute and relative contraindication, grade 1C. Now in symptomatic right and left shunt, it's a classical foramen oval. If you know you have one, you must absolutely stop the idea of sclerotherapy. And the relative contraindication is the neurological disturbance, including migraine, and in this case to be remained before previous from sclerotherapy. The recommendation 15, we recommend against routine investigation to write every time if you have something with foramen before foam sclerotherapy. It's an important point. Always for the neurological complication, for the migraine, the patient should remain lying down for a long period of time. It's a grade 2C. Avoid injection of a large volume of foam or perform liquid sclerotherapy, 2C2. The patient should avoid performing a Valsalva maneuver in the earlier period after the injection and decide on case-by-case basis, perform a benefit-risk assessment based in particular indication, grade 2C. How to prevent allergy? It's more complicated. To prevent, patient must be questioned. Incidence throughout previous sclerotherapy, or other allergies, and always have epinephrine. And how to prevent arterial injection is relatively clear. When you have the blood emanating from the needle, and if you have a pulsative, you stop, and use the color flow duplex. I think since we use the duplex for the treatment in general, we don't have any arterial injection. Thrombotic was the main problem, follow the recommendation from RABE and the guidelines European. Absolute contraindication, acute deep vein thrombosis and/or pulmonary embolism, long-lasting immobility or surgery, relatively contraindication, high thrombotic risk, acute superficial venous thrombosis, and in patients with a high risk of thromboembolism, such look for the thromboprophylaxis, avoid the injection of large volume foam, decide by case the risk. We recommend, it's very important, a maximum of 10 milliliters of foam per session. Higher foam volume are applicable according to the individual benefit assessment. Stop injecting if you feel resistant, stop injecting in blood forms, stop injecting in prolonged blanching occurs. How to prevent? Use the lowest volume and concentration, inject with slow, steady pressure, smaller surgeon equals greater pressure, be careful, ultrasound guidance. removal of coagula, sorry, direct puncture. For coagula, I do quickly, and please go slow when we treat. And sorry for the end, but the time. In final, how to prevent a good strategy, a good concentration, and a good volume at a good place. Thank you for your attention.
Thank you, Dr. Mako, for sticking on to the time schedule. Thank you. Thank you much. It didn't, it was too long. Next is an online presentation by Dr. Pauline Raymond from Canada on recommendations on foam sclerotherapy with interventional ultrasound. Welcome, Dr. Pauline. Good morning.
Hello, everyone. I would like to thank the organizers and especially Professor Rahul Jindal for inviting me to discuss today recommendations on foam sclerotherapy of varicose veins with guided interventional ultrasound. I have nothing to declare. Recent years, I've seen significant advancement and the evolution of different techniques used in treating varicose veins. And one area that has been affected by these new developments is foam sclerotherapy. A thorough but narrow literature search has been conducted from different online databases in line with the review topic. It is important to note that no limits were placed on the type of study retrieved. 216 articles have been reviewed. 19 publications were found to be in line with the inclusion criteria. In these 4 were CPGs, 1 an economic evaluation, 2 cohort studies, 7 RCTs, 15 SRS, and 1 NHDA. 3 major research questions guided this review. What is the clinical effectiveness and safety of foam sclerotherapy, the cost effectiveness, and the evidence-based guidelines regarding the use of foam sclerotherapy with INVIS for varicose veins? One of the aspects reviewed was the comparative effectiveness and safety of foam sclerotherapy versus liquid sclerotherapy. The total occlusion rates for foam sclerotherapy stood at 92%, while those of liquid sclerotherapy stood slightly lower at 75%. The second aspect related to the clinical effectiveness of foam sclerotherapy versus surgery. No difference was found between the 2 modalities regarding clinical and quality of life improvement. The third aspect involved FS versus EVLT. As well here, several of the studies reveal no difference between EVLT and FS regarding different clinical outcomes. Although the majority of studies were not adequately powered to detect safety complications, the overall rates of adverse events were low for foam sclerotherapy. Regarding the cost effectiveness of foam sclerotherapy, there are a few studies that have been conducted to assess the economic value of foam sclerotherapy compared to radiofrequency, endovenous laser, or surgery over a 5-year period, and the economic value of foam sclerotherapy was demonstrated. Clinical guidelines were found in the NICE study from UK, the American College of Phlebology, the Society for Vascular Medicine, the American Venous Forum, and the Society for Interventional Radiology. Several guidelines are specific to each country, so we did not include them in the review. According to the intervention-specific guidelines supported by the American College of Phlebology and other American medical societies, foam sclerotherapy is
We have lost audio, Dr. Pauline Raymond. Technical team, any problems here? Dr. Pauline, can you please wait? I think we have lost audio here.
Yeah.
Yes, I know, I see that.
Yeah, no, we got you back. Yeah.
And small veins.
Can you go back?
Regarding technique, the use of three-way stopcock and female-female connection received the grade 1A, room air 1A, CO2 O2 2B, volume 10 ml 2B, time between foam production and injection being short 1C, and ratio liquid to gas 1:4 1A. Now, what is lacking in the guidelines is there is no standardization of protocol. Great saphenous vein incompetence for a diameter of less than 10 millimeter is suitable to ultrasound-guided foam sclerotherapy. However, for a diameter over 10 millimeter, other modalities could be more successful. For pelvic corrosion, if there's no congestion syndrome, ultrasound-guided foam sclerotherapy is an accepted treatment. Perforating veins, the ultrasound-guided foam sclerotherapy has been recommended as a great treatment for that kind of vein. Tributaries for ultrasound-guided foam sclerotherapy received a grade 1C, and phlebectomy is recommended for veins of a diameter over 11 millimeters. Revaus is very successful with ultrasound-guided foam sclerotherapy. However, one needs to locate the arteries in the vicinity prior to injection. Small saphenous vein, due to the variability of the termination, ultrasound foam sclerotherapy is a good approach for the small saphenous vein. Thigh extension, also ultrasound-guided foam sclerotherapy is an excellent treatment. Giacomini vein also. Perforator of the popliteal fossa is a good indication for ultrasound-guided foam sclerotherapy due to the location of the tibial nerve. Gluteal and buttock veins are veins of difficult access, so ultrasound-guided foam sclerotherapy is also an accepted treatment. We don't know what we don't know, and it is important to study in detail the mechanism involved on the formation of bubbles, as well as bubbles' behavior on the blood vessels and how they influence the blood flow. There are many factors that influence the bubble behavior, and some of them are vessel diameter, foam composition, bubble shape, vessel bifurcation, coalescence, and liquid to gas ratio. The foam evolves during injection, and we can't predict its behavior. There is a lack of established guidelines on treatment injection flow rates, and it makes it difficult to presume the injection shear rates experienced by the foam. In conclusion, INVIS is the gold standard for the assessment of C2-C6 veins. Foam sclerotherapy is safe and effective to treat C2-C6 veins. However, there is a lack of guidelines for foam sclerotherapy protocols injection for management of C2-C6 veins. Pathological events caused by bubbles trapped in blood vessels need to be better understood, and dedicated experiments need to be designed in the future to extensively evaluate the correlation between shear-induced aging and rheology of sclerosing foams. Thank you very much for your attention. Hello, everyone.
Dr. Pauline, please stay on. We have one or two questions for you before you go.
Thank you.
Pauline is, dear friend of VI, and she's also the president of Canadian Society of Phlebology, and she's also conducting an annual conference in April, and Dr. Padaria is part of it, and and representing VI, and she's a very important person, and she's also the education committee chairperson for UIP.
Professor Rashad, we do recognize your presence here from Egypt, all the way from Egypt. I'm sure that you have some comments or a question on what Pauline presented.
I have a question regarding the use of carbon dioxide with air. Have you seen any difference in the quality of the foam when you use just air or carbon dioxide? That's one question. Second is you mentioned SEPs. Is it still being done in Canada?
No, no. We pretty much for perforator use foam sclerotherapy. In Canada, due to the health system, the varicose vein treatment is not covered by third party, so it's more cost effective to do sclerotherapy, and the Canadian physicians are very skilled and proficient in sclerotherapy. So SEPS is not a procedure that is performed. Now, the other question was air, I think, versus CO2, if I'm not mistaken.
That was the question, yeah, that's correct. Carbon dioxide versus air.
Yeah, we pretty much use room air for preparing the foam. Very few physicians will use a CO2, but it's not the majority.
We'll move on and realize in the time there is one aim. Thanks for staying up so late for us. Thank you.
Thank you very much.
We'll move on to the next presenter, Dr. Niranjan Bhattacharjee for EVDT for varicose veins.
Namaste. Dreaming with one's eye open. Every great advance in science has issued from a new audacity of imagination. बचपन से आज तक तो वही सुन के आ रहे. But if you permit me, I would like to show you the other side of the coin. Let me skip few slides here. The time is very short. Anyhow, here I'm not going to narrate any story of depression. But one thing, till that in our medical science, we are really a copycat. But we are moving from there. Look at Diageo, look at HAL, and I think one day will come when we will establish our setup and everything according to our people. So, let me give an example of such a very much debatable issue to this learned vascular surgeons, of course, on the varicose vein. See, the modern treatments we are all discussing, EVLT, radioablation, and many more. But unfortunately, all the medical colleges in West Bengal, in private and government, there is no facility for these advanced treatment. 72% of the population of my state come to the government hospital because they are not economically sound. The boys who are passing, girls who are passing Master of Surgery without any practical hands-on on that and proper knowledge. So, a new thinking may be much more debatable. Many hours to spend on that, many things to be done. Still, let me present it before you with courage. EVDT, endovascular diathermy therapy, and when necessary to combine with foam sclerotherapy. So what we need, as we make a synopsis, we need a diathermy generator which is available in rural hospitals, rural small nursing homes also, and a digital thermometer, but with a little bit facility, which can auto-cut the generator circuit, that is the power circuit, that is the diathermy automatically, when a preset temperature is get there, and a complicated little bit maybe, a electrode or a catheter with a magnetic tip and two electrode connectors, a glowing tip so that we can monitor With a metal cap and with a magnet on the surface of the skin, we can guide it nicely through the vein. Then our insulator, then the first electrode, then the insulator again, and finally the return electrode. This thing we do. See, some doctors, many of you, are capable of imagining and crudely designing something new to solve a problem, and also can conduct some experiments or do drawings to explain their ideas. But they are not capable of giving it a final shape unless the engineers apply their knowledge and skill to complete it. So, still it is an imagination. The same thing is going on. Engineering colleges, one of the evidence I have given here, we have tried, they could not develop it. What to do? To spend time? No. That great mantra, failures are the pillars of success. So we were moving like a toy train of Darjeeling, and we decided, even we could not pass the ethical committee of our college, so we have decided we will do it in a small nursing home, 18 kilometers away from Chuchuro. There is a Mogra, only 20-bedded nursing home. See the diathermy machine, don't laugh, but it has got a bipolar option, of course. And this is my electrode, see how I have connected it. We, it's not me, my team. So, look at the tip, it's an infant fitting tube with copper wires coming out, and we can inject a little bit normal saline through it while we are firing to facilitate the current conduction, you know. Then, these common things, and ice pack and preloxicin ointment as a local anesthetic agent. Complicated mathematical calculation manually, so you need a ohms meter there, a calculator, because the difficult part is what should be the firing time. See, Bachpan ka formula I square RT is equal to J. So, watt into time is equal to J. That is time is equal to J by the watt. Now, we have to fix it at 20 watts. We have done it there. So, we practically, if we can rise the temperature in the vein 90 degrees centigrade for a aseptic thermal injury, that is from inflammation, with the objective of synecdoche of the vein, that is adhesion, fibrous adhesion, then we can clock the vein. That is the basic thing that we could understand. So 20 watts, the time is at 90 joule. Well, at the 90 joule, that is equal to 52 degrees centigrade, the cell necrosis starts. But we were a little bit conservative at this moment because of the first experiment. So, time should be 4 seconds. That should be the firing time. No, it's wrong. We need a correction of the firing time because you know the coagulation current, there is a barges of current. 60% of the time, the generator barges electrical current, and the 40% of the time, the generator slips automatically. So by this simple calculation, we can add 1.6 second with that, and the firing time should be 5.6 seconds. And that we have to do it manually. So, a generous patient, ethically, unethical, or unethically ethical, I am not going into the debate. Kartik Pal is a patient. So these are the follows. The time is running short. I can show you everything. So these are the results. So we expect that our country's policymakers will rise to the occasion empathically, and thereby more and more inventors and inventions will be produced in our country in the near future. My favorite poster, look around, think and solve your problem with imagination. Jai Hind. Namaste.
We have come to the end of the session and we can start taking questions now. Since Dr. Bhattacharya is on stage, any questions regarding this last presentation? How much is the average cost per patient? So this
Sir, actually, I'm suffering from acute deafness of left ear.
how much is the average cost per patient?
Oh, about the cost, sir. You have seen the generator. I think a little bit good generator which is available, diathermy machine, available in everywhere, in the rural areas also. It costs around a good generator, how much? I mean, 90,000, 1 lakh. That's enough. I don't know about the catheter, which should ideally be done, the electrode containing. That's yet not, it's in the dream. No one could make it for me. And rest of the thing, I don't know how much it is, you can see.
It's not very expensive.
Not at all. Not at all, sir. Okay. And about the foam sclerotherapy, you know, is very low cost procedure. So, where the 72% people of our country who suffer, 16% suffers from the poverty, lower middle class and upper middle class cannot afford the best possible treatment by the best possible experts in our country. Where will go, sir?
Thank you, Raj. Questions to other speakers? Rahul's presentation. I have one question. Rahul, one question to you. You showed the big bunch of varicose cheese, and what sort of anesthesia do you use for this one? The patient with the huge varicose cheese. Is it blocked or local?
No, but is he giving the medicine?
Oh no, that I don't know. You have to ask.
I'm asking for the EVD teacher. Dr. Bhattacharya was...
If there are no further questions, we come to the end of this session. Thanks to all the speakers for a brilliant session. A lot of carry-on. Oh yeah, Rahul, yeah.
Yeah, can I ask a question to Dr. Gulshanjeet? Is he here? Hello, sir. Sir, we have used retrograde techniques here in the recurrent varicoceles. I've got 2-3 questions and points observation. One is, unilateral varicoceles normally does not cause a sperm count to go down, and because if you have a normal testicular function on the other side, so normally because you showed in the presentation your testicular, the sperm count improved, the mobility improved. So normally in unilateral improvement in the functions, after ablations, normally such a drastic improvement normally is not reported. Second was that if you want to go retrograde with a vein cannulation, you can also do ultrasound guided percutaneous. So we have done it. So we don't need actually to dissect the spermatic vein, and you can puncture this vein retrogradely. And third, I saw you were putting in a liquid sclerosant. And why not foam? Because you can get a better results. Second is you can mix up the foam with the contrast, and we can exactly see how much foam we are giving and where exactly that thing is going.
One question for Dr. Mako. What is the time limit do you wait for the draining of coagulum, sir? After foam sclerotherapy, when do you do a coagulum drainage? Drain the clot out. Clot. Post sclerotherapy clot. When do you get them out? No, you don't.
In echosclerotherapy, if you are waiting the spasm for the treatment, in general you don't have a lot of quantity, and in more, your veins is not really with foam, already with inflammation, and for that, the main question is, at my opinion, the question of volume. I think very often we decide to treat the patient, the veins, and you don't look about the spasm with the duplex. And with the spasm, in general, with 2-3, maximum 4 millimeters, you have a spasm, and you can look after with a probe if it's okay or not, and try a second time if you need more. But I think if you do that, you don't have any clot.
Thank you, Rich.
Yeah, regarding Dr. Rauljinder question, saying that unilateral varicocele is not a cause for infertility, but we have been running infertility clinic for 10 years, and we found lot of patients coming with a unilateral varicocele. So the sperm count was low in these patients. And regarding the injection percutaneous, we have not tried. We tried open technique only. But percutaneous, some people have tried percutaneous cannulation. And regarding the third question that the foam has to be injected, we tried only sclerosant with the air block technique, not the foam.
Thank you so much, sir. Thank you to our chairperson. Thank you so much for our panelists.